Hello, my name is Edwin Aguilar, and today I will be presenting a case on the proximal hamstring avulsion in a collegiate football player. Let's first touch on the topic of anatomy of the hamstring muscle complex. The hamstring muscle complex is located in the posterior thigh, comprising the semitendinosus, semimembranosus, and biceps femoris muscle. Hamstrings arise from the ischial tuberosity crossing both the hip and knee joints. Hamstring avulsions are prevalent in sports that require high velocity sprinting, jumping, and deceleration. This is due to an eccentric contraction of the muscle group during these motions. A common symptom of hamstring avulsions is sharp pain due to the rupture of musculotendinous fibers. Additionally, you will see or observe a decrease in lower extremity control, especially during the late swing phase of gait. A common way to diagnose hamstring avulsion consists of an ultrasound, an MRI, and patient history. Treatments include a surgical repair of the hamstring or a conservative treatment, also known as a non-surgical approach. Let's move on to the patient case. The patient is a healthy 21-year-old male collegiate football player. He has no history of hamstring pathology. During practice, he felt a pop when catching a ball with his right hip flexed and knee extended. He immediately felt sharp pain on the posterior aspect of the thigh. Physical examination. An antalgic gait due to limited hip flexion and knee flexion were observed. Additionally, no immediate swelling was observed during the sideline assessment over the hamstring musculature. However, the hamstring muscle belly was prominent due to retraction, therefore a clear deformity was acknowledged, and a palpable defect and tenderness over the ischial tuberosity was also reported. His hip passive range of motion and active range of motion were both limited due to pain. His knee passive range of motion and extension and flexion were both limited due to pain. His active range of motion and knee flexion was a 3 out of 5 in strength, and his extension was intact but with a 4 out of 5 in strength. His deep tendon reflex over the hamstring was a 2 out of 4, meaning potential tibial nerve involvement. An ultrasound over his hamstring musculature demonstrated limited visualization of hamstring ischial attachment and hemorrhaging along the biceps femoris. An MRI T1 axial view showed a complete avulsion of the proximal hamstring tendon. The patient decided to undergo a hamstring repair. An endoscopic repair of his proximal hamstring avulsion was performed. This surgery is usually performed with the patient in the prone position with two working portals in the gluteal fold, one directly posterior and the other posterolateral. This is followed by identification of the torn tendons and fixation to the ischial tuberosity with suture anchors. Postoperatively, for the first 0 to 6 weeks, his knee was locked at 90 degrees of flexion with a knee hinge brace to allow approximation of the tendons to the ischial tuberosity. During this period, passive range of motion was performed first at 45 degrees, then 15 degrees, and eventually 0 degrees of knee extension. There was to be no activation of the hamstring musculature. From 6 to 12 weeks, passive range of motion to 90 degrees of knee flexion, active knee extension, and weight bearing as tolerated was implemented. He transitioned from a scooter to crutches and started the process of gait retraining. From the 12-week mark and up, strengthening the hamstrings through isometrics, cardiovascular through the recumbent bike, and further progression of gait retraining 3. Aquatic therapy was implemented. Conclusion. Despite there being numerous hamstring grade 1 and grade 2 injuries, hamstring avulsions are rare. They account for approximately 3 to 11% of all hamstring injuries, and they are usually diagnosed in predominantly elite athletic populations. Early recognition is important. Failure to report a hamstring tear may lead to mismanagement, which may have a detrimental effect on the patient's outcome. In this case, surgical repair over non-surgical repair led to a positive outcome, a reduction in pain level, and a high likelihood that the patient will return to regular or near regular hamstring strength. The patient will most likely return to play in the upcoming football season. Clinical bottom line. For individuals that are planning on returning to the same or similar level of physical activity, hamstring repairs have a higher satisfaction rate. This is important for athletes who want to return to their sport. It's important to consider the diagnostic use of ultrasound. In this case, it was a diagnostic tool that was quick and inexpensive. If the tear is diagnosed and addressed via surgery within the first few weeks, repair of the tissue can result in normal or nearly normal function. Lastly, prevention of hamstring pathologies is an important topic that should be further researched.